Patient is a 71-year-old widowed white male. His former job was an industrial engineer, but is now retired. H was brought to Heartland for weakness and inability to care for himself related to multiple sclerosis, and primary caregiver is deployed in the Marines at this time. H was diagnosed with MS in 1983 via spinal tap. He had originally went to the doctor after standing in a pool and having a burning feeling where the water was touching his waist. H has had no pain associated with his condition. Aggravating factors include hot or muggy weather. Alleviating factors include cool weather. Patient states that condition has worsened over time. Patient states associated symptoms as weariness, weakness, floppy motions, and incontinence. Health history. Past medical history includes measles under the age of 12. Patient refuses immunizations because he states he is up to date on shots and refuses the flu and measles immunizations because they have deleterious effects on his MS. Allergies include Indocin, in which vomiting is the reaction. H has had multiple recent hospitalizations for UTIs. Surgical history includes childhood appendectomy, multiple gunshot wound to the right ankle, right hip, and right arm, fractured clavicle, and 6 small bowel perforations. Current medications include Copaxone 20 milligrams per milliliter injected 1 milliliter subcutaneously in the morning for MS, methenamine hippurate 1 gram by mouth 2 times a day for prophylactic for infection, multivitamin 1 tablet by mouth in morning for supplement, oxybutynin CLER 5 milligrams orally 2 times a day for urinary retention, and Prozac 30 milligrams by mouth in the morning for PTSD. Functional assessment. Patient reports no sleep disorders. Patient has difficulty eating full meals, states his eating habits as a grazer. Caffeine intake includes 1 cup of coffee each day. H reports his nutrition is very poor and says he has no nourishment goals. Use of safety devices includes a walker and a wheelchair. Tobacco usage since patient was 18, smoked up to 3 packs a day but quit in 1969. No drug use otherwise. Patient states alcohol use is limited to 1 beer with dinner. Patient states that he has no perceived stressors after retirement, although there was high stress previously related to occupation. Environmental hazards include trichloroethylene and asbestos during time in war. Patient identifies as Roman Catholic. Patient states his coping strategy is thinking things through. Patient has a bachelor's degree in industrial engineering and completed some grad school but left because of worsening MS symptoms. Interpersonal relationships include mainly family and a few friends in Illinois. Family history. Mother died from renal cell carcinoma in her 60s. Father died from MI at age 69. No known prior heart disease. Brother had bipolar disorder and committed suicide. General review of systems. Patient describes health as good except for the MS. He states he is most stable with the exception of MS flare. He is stable as well. Patient experiences no fever, chills, or night sweats. H experiences no excessive fatigue aside from MS flare-ups. He does experience heat and cold intolerance, but it is not new and it makes him very fatigued. Neurologic mental status systems. H experiences tingling toes and sensation in the soles of the feet occasionally. Patient states he is not concerned about memory, but sometimes is concerned with his ability to concentrate. H has had no problems with insomnia. Unsteadiness and loss of balance are not applicable to H due to being wheelchair bound. Coordination is not an issue. Anxiety does not interfere with daily activities. Patient does not have difficulties with speech. Past history of head injury includes severe concussion during time in war. Musculoskeletal review of symptoms. H denies history of arthritis. Patient has swelling of the legs and ankles and pain in the ankles and knees. Limitations in performing daily activities include walking. Patient states he has weakness in the right leg. Physical examination. Neurological. Appearance was clean and hygienic. Patient was alert and oriented. Facial expressions were present and appropriate to the situation. Normal speech patterns, sentences were complete and logical. Patient oriented in both person and place, but not time. Attention span, short and long-term memory, abstract reasoning, judgment, and thought process were all normal and expected. Patient had some difficulty with intellectual ability as evidenced by struggling with the serial 7's task. Patient unable to perform general motor function, balance testing, and Romberg test due to physical limitation. Normal and expected upper extremity fine motor function during finger to nose, examiner's finger then nose, and rapid alternating movement tasks. Light touch sensation, painful sensation, and vibratory sensation were not performed. Patient demonstrates 3 methods of evaluating cortical and discriminatory sensation with normal and expected stereognosis, graphesthesia, and proprioception. Babinski reflex and ankle clonus were both negative. Musculoskeletal physical assessment. Muscle mass and bone structure were all proportional and expected. Patient is wheelchair bound and unable to perform assessment of posture and gait. Spine was straight, so assessment for scoliosis was negative. Full range of movement in all joints. No erythema, warmth, inflammation, pain, or crepitus found on assessment of TMJ, neck, shoulders, elbows, wrist, fingers, hips, knees, and ankles. Unable to assess hips and spine. Muscle strength of deltoids, biceps, triceps, wrists, and fingers were all 5 with full range of motion against gravity with full resistance. There was no assessment of hips, hamstrings, and quadriceps due to patient being wheelchair bound. Other pertinent systems. According to the Multiple Sclerosis Journal, it is important to assess the genitourinary system for patients with MS. About 80% of MS patients suffer from lower urinary tract symptoms. This is important because neurogenic detrusor overactivity or underactivity related to neurological function in MS is what causes these symptoms in patients with MS. It is important to assess this system because these symptoms tend to worsen over time and can lead to UTIs and even the need for self-catheterization. According to the Multiple Sclerosis Journal, it would be important to perform a cardiac and peripheral vascular assessment on patients because of the risk of MI, stroke, heart failure are increased in patients with MS. Lack of activity due to other side effects and preoccupation of treating the other side effects makes cardiovascular risk higher in those with MS.